Good evening, and thank you for joining us. I'm Deborah Livingston, and I'm the Development Director with the Mayfield Education and Research Foundation. Welcome to our next installment of Brain Talks, our webinar series created to improve your brain health. We're picking up this evening after our April webinar, where we were provided with an overview on brain tumor types and treatments. Tonight, we are joined again by Dr. George Mandybur here at Mayfield Brain and Spine. Dr. Mandybur will help us learn about new developments in deep brain stimulation for Parkinson's. Thank you, Dr. Mandybur, for joining us this evening. Before we start, let's take a moment to ensure that everyone is ready and familiar with the webinar control panel, which is located on the right side of your screen. First, you can minimize this panel by clicking on the orange arrow in the upper left-hand corner. You can expand the panel by clicking the same button again. Second, you have the ability to submit questions using the question pane located on the control panel. If it's not open already, just click that question bar to expand it, and you will see where you can type and submit questions to us at any time. While we are not able to respond to your question live tonight, we will provide a response to your questions via email in the next few days. Finally, this webinar has been recorded and will post online at mayfieldfoundation.org for later reference. Now let's get started. We are very honored to have Dr. George Mandybur join us. This is Dr. Mandybur's second presentation in our Brain Talks and Spine Talks series. Dr. Mandybur is a neurosurgeon here at Mayfield Brain and Spine and a great friend of the Mayfield Foundation and serving on our board. So Dr. Mandybur, welcome back and thank you for being here. You may now begin your presentation.
Well, thank you again for having me do these webinars. I am Dr. George Mandybur. I'll be talking about the Parkinson's disease and some newer developments within the surgical realm, and I will talk also some medical and non-medical treatments, which are interesting to review. We'll basically break down in 4 categories, basically Parkinson's disease, and go over what we believe it is, some medical management of it, where a lot of it is mainstay nowadays, surgical interventions, and a large part of that will be the deep brain stimulation, and for future treatments that are on the horizon. Well, first off, we'll talk about what is Parkinson's disease. Parkinson's disease seems to be a neurodegenerative disorder affecting deep inside the brain dopaminergic neurons. So what we see is in areas within the brain stem, which would be the center part, if you take sections of that, you see in the left-hand upper image, looks like a Mickey Mouse. The base of the ears are dark. Substantia nigra means dark substance in Latin. And so you can see in the second slice underneath, the Parkinson midbrain, where you see at the bottom of the ears, as it were, that dark area is much paler. So the substantia nigra has gotten smaller. This has to do with the cells dying out. Because the cells are dying out, these neurons produce dopamine. So there is less dopamine within the system. And so dopamine works as a modulator within the nervous system, and certain more advanced movements become difficult to do. Patients with Parkinson's have good strength. They are not weak. What their problem is to be able to coordinate movements and to make movements rapid and effective. We think that what's going on with a lot of these neurons is that there's protein clumping within the neuron. Call it intracellular garbage that the cell doesn't take out. And because of that, it just accumulates and pollutes the inside of the cell. This is an ongoing theory of the underlying cause of Parkinson's disease. So how do we know you have Parkinson's disease? Well, there are no blood tests, so we need to go by clinical presentation. So there are certain characteristic clinical signs that we look for. One of them is rigidity. This is a stiffness caused by the involuntary increase in muscle tone. So if you move your arm around or somebody tries to move the arm passively, they can feel a resistance rather than a nice loose arm. A normal person, when you move the arm, it's very lax and loose. In a patient with Parkinson's disease, you move the arm and it'll be stiff. We use different kinds of terminology to describe that rigidity. One is lead pipe rigidity, meaning it can bend, but it takes some pressure. Another one is cogwheel rigidity, where there is a intermittent release lock as you're moving the arm. These are pretty characteristic of Parkinson's disease. Many patients also will have tremors. As you may know, this has to do with involuntary shaking. These tremors typically are resting. So when the patient is just resting, sitting, the arm is not doing anything, that's when the tremor comes out. When the patient starts to use the hand, the tremor may diminish or extinguish completely. Another symptom may be bradykinesia or akinesia. What this means is a without movement or slow movement. So the general movements are pretty slow, so they don't have the speed at which they normally would have. Gait problems, so walking problems, you'll see patients having difficulty standing up from a chair. When they start to walk, their feet make very tiny steps and they shuffle. Sometimes the shuffling gets so bad they freeze, meaning their feet just kind of stick to the floor. Along with this, you'll notice patients will have a stooped posture, typically across the spine, with the head and neck kind of stooping downward. There are many other signs of Parkinson's disease, and some of these are variable depending on the subtypes of syndrome. Parkinson's disease is a bit unusual, and you can notice that very few two patients will look exactly alike. Some will have tremor, some won't have tremor. Some will have cogwheel rigidity, some will have lead pipe rigidity, some may have all of that. In addition, patients will have a mask-like face. Many of them complain of difficulty sleeping, cramping, this dystonia. Many will have depression and discomfort and pain. Skin disorder like seborrheic dermatitis, especially on the scalp, is very common. Drooling is also pretty common, especially early on or untreated. Low voice, we call hypophonia. So, the spouse is constantly telling the patient to speak up, they can't hear them. Small handwriting, and this is sometimes an early sign where patients will notice that their handwriting becomes more illegible and very small. Cognitive difficulty and dementia typically are more later seen in Parkinson's disease, but dementia can be seen up to about a third of the patients. We'll go on here, and we have to also differentiate Parkinson's from other neurologic syndromes that may look like Parkinson's disease initially. A very common one is essential tremors. Essential tremor is not Parkinson's disease, but early on is sometimes difficult to differentiate. Again, since we do not have a lab test or a scan that can definitively say you have essential tremor or you have Parkinson's disease, especially early on in the syndrome, it's difficult to discern one versus the other. So this is important to review. Multiple sclerosis is considered in neurology the master of mimicry. Because multiple sclerosis can affect any part of the nervous system, patients with MS can look like Parkinson's in many cases. So we have to look for all these. And there are many others here: olivopontocerebellar atrophy, MSA or multisystem atrophy, PSP, or progressive supranuclear palsy, and vascular Parkinson's. All of these that are being listed here are not Parkinson's and need to be differentiated and are typically treated in a different manner. Some can be treated with surgeries, either with what we're going to talk about or something very different. Some general facts about Parkinson's disease. It's quite a frequently occurring neurodegenerative disorder. It's one of the top several neurodegenerative disorders in the United States. I think over 1 to 2 million people within the US have Parkinson's disease, with at least 60,000 new diagnoses per year. From a medical cost point of view, it is a very expensive syndrome, costing at least $25 billion per year for all treatments. But PD patients that potentially can benefit from DBS, it's somewhat argued on, of that 1 to 2 million, how many and what's the percentage? Some will say 5%, some will say 20%. I think as we're learning about the procedure and the syndrome, the number is increasing, not decreasing. So this would give us between 50 to 200,000 potential surgical cases. Actual surgical cases, though, is much less. Now, the 50 to 200,000 that I mentioned was just for the United States alone. Worldwide, it's probably 140,000 total DBS implants since DBS was first introduced in 1997. It's figured somewhere to about 5,000 cases are performed yearly worldwide. So the big question is why so few people are getting DBS when there may be as many as 200,000 patients within the United States alone that could be good candidates. And, you know, there are many answers to this. Some of them, the question is not fully answerable. Patients don't know. Doctors are not familiar. Some think that this procedure is scary or experimental. Some will think that the side effects of surgery are too worrisome and just take medication instead. We'll try to answer some of those questions along the way here, and at least give you insights and help answer your own questions. So first off with treatment, so early on in Parkinson's disease, we treat with medications. And there are quite a number of different categories we can use. Levodopa is the most common. Dopamine agonists are also very commonly used together. And you can see also the COMT inhibitors, MAOB, and such like. And there are several others I didn't list here, but if you talk to the neurologist now, it's every other day, there's some other new medicine coming out. The thing that to note is some of these medications are just reformulations of medications already available. Either they're made in more long-acting or a different type of absorption, or made in patch form, so easier to take. Some have become injectable and to give quick onset. But basically, the mainstay is levodopa and the dopamine agonist. We've also learned over the last decade or so that exercise and physical activity is extremely important in neurologic disorders, and especially in Parkinson's disease. So we find that exercise programs, excuse me, dance for Parkinson's, power moves, all these types of physical therapy and exercise programs, some of them are geared directly for Parkinson's disease, are very helpful. The use it or lose it attitude is very prominent within the Parkinson world, and so they've learned this. And I find that patients seem to like a lot of these exercise programs, and they give a bit of a social interaction as well, which is also important. And then finally, we have surgeries. Surgery for Parkinson's disease has been around for a long time. It actually predates the medical use of treatment for Parkinson's disease. surgery for Parkinson's disease has been around over 100 years. And we'll talk about some of the newer procedures. So let's talk more about the medications and understanding on how some of these medications work. So I talked a lot about Sinemet. Sinemet is a combination drug of carbidopa-levodopa. Levodopa is the active ingredient. The carbidopa is what limits the side effect of the levodopa. Levodopa taken straight up may make a lot of people sick, ill, nauseated, headachy, a lot of side effects there. And the carbidopa helps limit some of that. This was developed actually in the 60s and has become the most effective single treatment for Parkinson's disease since then. And even today, it's still considered the mainstay for treatment for Parkinson's patients. Many think that if you delay the use of delay the use of Sinemet, you delay the progression of the disease. That is not true. And that if the medication stops working, that means the medication is just, you've become desensitized to it. Really what's going on is that the patients just progress in their syndrome. Fewer of those dopamine cells are around. That circuit is becoming degenerated, and so there's not much circuit left to stimulate with the medication. And that's what's happening as we see with early Parkinson's disease. You see on the graph where you have a large area under the graph where you have a decent response. In moderate Parkinson's, you see a smaller area, and more advanced, even a smaller area, where you get very small windows of good activity from the Sinemet. So again, here's another list of medications, and these are general categories, and a lot of these are available nowadays. A lot of these will be used in combination as well. Typically starting out with carbidopa-levodopa and the dopamine agonist, and a lot of the others will be added as needed, usually not in the beginning. But it's very patient dependent, so some patients can tolerate certain medications better than others. And just because you take 2 Sinemets at a time every few hours, and another person takes a half a pill only a couple of times a day, that doesn't mean that the person who takes more medication has a more advanced syndrome than the patient taking less medication. Physical therapy and exercise recently is gaining a lot of attention in the neurosciences. Especially in Parkinson's disease, we find that especially pretty strenuous exercise can be very beneficial to a lot of these patients. And we do recommend this. We aim for about 30 minutes to an hour, at least several times a day. It is recommended 4 to 5 times a day. And this is an American Neurological Society recommendation for most people with any neurological syndrome nowadays. Excuse me. Studies are even showing that exercise, especially strenuous exercise, can be neuroprotective. So slow down progression. That's kind of what we're looking for. So let's start to talk about surgical treatments. Again, surgical treatments are nothing new. General surgical ideas for interventions in Parkinson's disease have been around since the early 1900s. They gained popularity back in the late 40s to the 60s, just before the invention of the levodopa. We were learning about the nervous system, the brain, how it's connected, and a lot of the interventions were actually pretty effective. Many of the targeting and concepts we have now come from a lot of that. So why are we going to these areas inside the brain nowadays? We attribute to all the work that was done back in the 1900s. The procedures nowadays can be selected into two separate categories. One is an ablation, so basically making a lesion, and deep brain stimulation, or modulating this area. So under the ablation, we have high frequency ultrasound, which is become a new thing you may hear about advertised a lot. It's a new tool. It's looking for some kind of intervention. VIM thalamotomy is another one. This has been around for a long time, and so has GPI pallidotomy. Both of these last two have been around since the 50s. Deep brain stimulation, the concept of, has been around since about the late 60s, but the equipment and the technology wasn't there yet. In the 80s, it started, but it kind of sputtered. It wasn't until 1997 when there was FDA approval for the first deep brain stimulator. And since then, things have gotten pretty good with regards to development of new equipment and surgical techniques. We can target many areas inside the brain very effectively with this device and very safely. Since we're not creating a lesion, we're actually intervening within the nervous system itself and modulating the nervous system. So more like part of the nervous system rather than just cutting a circuit. And the targets are similar as there were in the ablative category, the thalamus, the pallidum, the GPI, and the STN. Radiosurgery is a form of high precision focused beam radiation. It can create an ablative procedure. This is something that is available today. There is a well-known tool called the Gamma Knife. It's available in most cities, and it's a relatively straightforward outpatient procedure. Can be accomplished pretty much in several hours. Really does not require much anesthesia. This is an ablative procedure, so it's creating a lesion, and once it's done, it's done. There's no undoing it. Focused ultrasound is very similar to the Gamma Knife. It uses MRI guidance directly, and like the Gamma Knife uses gamma rays. The focused ultrasound uses high frequency ultrasound waves. Both use the same multi-parametric focus onto a target, and they are ablative. So you get an ablation with the radiation, and you get ablation with the sound waves. There are some advantages, disadvantages to each of these. The focused ultrasound can give you the result very quickly. The Gamma Knife may take weeks for it to take effect. The focused ultrasound typically requires a long stay within the MRI machine, can be several hours. Typically, patients are awake for the whole thing. And as far as I know, they require an entire head shave. Both of them require headgear to be mounted in a similar fashion to hold the head still during the procedure. Both are outpatient procedures. So we come to deep brain stimulation. What first I want to talk about is the components themselves, so we understand what we're implanting. A simplistic manner to look at this is think of a heart pacemaker, where you have a battery and some wires. And so as heart pacemaker, the wire goes into the heart and helps modulate the heartbeat or fix the heartbeat when it's not right. This wire goes into the brain in DBS and helps modulate the brain in patient with Parkinson's disease and some other syndromes. So what typically we'll see is like the top category, you see DBS leads, a very thin wire. In the middle, you see several different types of batteries. Some of these batteries are rechargeable and some of them are not. It is typically the patient's choice. And with the rechargeable batteries, you'll have a longer life with the battery. It'll last you longer. But with the non-chargeable, you don't have to fiddle with charging it. Typically, charging is like with the gentleman in the lower box there. Takes about an hour or so every few days. The amount of charging will be dependent upon the settings on the device. So it can be as often as every few days or as infrequent as once a week. Rechargeable versus non-rechargeable. Typically, we have non-rechargeable systems. They're slightly larger than the rechargeable systems, but few patients really see that the difference is a big factor. I would say two factors are important to consider the differences between the two. One is longevity of the device. So a smaller rechargeable battery can last you 10 to 15 years if you keep it healthy with charging it regularly. But if you're forgetful or you don't want to fiddle with it or you're not very tech savvy, then maybe a non-rechargeable is better. And some of these may last many years as well, up to 3 to 5+ years. Excuse me. The overall effectiveness of DBS has really become less of a question nowadays. There are many studies that have been performed over the years to compare deep brain stimulation's effectiveness in patients with Parkinson's disease with some of the best medical management that's available now to most patients. And these have been published in very reputable journals throughout the world. Here are just two citations. And these are from more than 10 years ago. One is the JAMA and the other one's the New England Journal of Medication. New England Journal of Medicine. And both of these have shown significant improvements in patients who've had DBS over medical management. And I'll go over some more details of that as well. The bottom line here is DBS has been around for a long time. It's been vetted quite effectively. It is not an experimental procedure. It's been around for more than 20 years. The FDA approved it in 1997, and it's been proven to be effective. So after all this, who's a candidate for DBS? Well, a lot of this will also have to do with what does the patient want and what are the patient's needs. So we'll typically say when the medications lose their benefit and they start to have that shorter window. So remember the graphs that I showed earlier, those 3 graphs. So this one looks like more like the middle graph, where you're starting to lose time during the day where you're not in that good on time. And when we say on, is when the patients take the medications, they feel the improvement, and how long does that improvement last? So patients who have Parkinson's disease or caregivers who take care of Parkinson's disease will know quite readily, when the patient took the medication and when the patient should be taking their next dose, just by looking at them, what their clinical status is. Tremor returns, tremor goes away, they start getting dyskinesias, and the such like will help kind of tell where they are in their cycle. This is what we call the on-off cycling. And when the cycling becomes severe or difficult to manage, these are times to start to consider, okay, maybe I need to think about something more. Patients typically will complain of dyskinesias, that wiggling motion, typically seen after taking medications, tremor that either won't go away with medication or quickly returns as medications fade, the stiffness, that bradykinesia that we'll see in a lot of patients, and gait problems, so difficulty walking and getting up. So again, when is the right time for having these procedures? I like to use the Goldilocks principle. and this seems to be something quite common now in science. There's a too much, too little, and just right, or too soon, too late, and just right. Too late is very important to think about. So you wait too long, you will pass your window for good intervention. Too soon is less of a concern nowadays. Earlier, younger patients, they're healthier. Healthier patients tend to do better with any kind of intervention. And as we're seeing, and I'll show later on, that there may be some other added benefits as well. I can't tell you any one particular patient exactly when is the best time. It's hard to say because it's so individual. But again, it's probably better to err on the earlier rather than too late. When we review patients for surgery, we typically will do a unified Parkinson's disease rating scale. This is a pretty advanced scale that's been developed by neurologists with movement disorder specialty. And it's a point rating scale and really looks at the whole patient. So, what's their thinking like? What's their activities of daily living like? Their ability to move their hands, what kind of tremor? Do they have dyskinesias? How bad are they? And do they have complications of therapy? Do they, when they take the medications, do they have hallucinations? Do they have a lot of dyskinesias? Things like mood disorder from the medication as well. So some medications can cause compulsivity as well. So these things all kind of play into this rating scale. So who's not a candidate? Well, primarily when we do our evaluations on patients, all the patients get a pretty involved neuropsychological evaluation. So a psychologist will see the patient and spend quite a bit of time with them, evaluating them, saying what's going on, do they have any, do they feel bad, do they have depression or other kinds of problems, what's their thinking like, are they forgetful, things like that. And these are important because if patients are later in the stage and they're starting to get more cognitive problems and more memory issues, then surgery may become less effective. They're starting to get in that too late Goldilocks level. And that's on the downside of the Parkinson's. And surgery becomes less effective. Patients become more fragile and more apt to have complications. Patients who have taken medications and failed to respond. So say, for instance, they've given you the diagnosis of Parkinson's disease and you've taken these medications, but you don't feel like it improves you. It may be one of those look-alike syndromes I mentioned earlier. And sometimes it may take some time to figure those out because early on, some of these patients may look very similar. And since there's no blood test that I can tell one versus the other, it just sometimes just time will tell us what you got. And failure to respond to medications is a strong indicator. And there are occasions where patients who have essential tremor who are diagnosed with Parkinson's disease, it's not Parkinson's disease, it's actually essential tremor. These patients can be treated with DBS, but in a different fashion and a little simpler. Typically, we also look for atypical features outside any gait and posture disabilities. So patient with orthostatic hypotension, swallowing disorders, those type of things, your neurologist can help vet some of those. Those are typically not helped with Parkinson or the DBS and may show atypical Parkinson-like features. So say it's a good candidate for DBS for Parkinson's disease. We'll do the surgeries. We have several different types of procedures. I'm going to go through the standard one that we do, and we'll talk about some of the newer stuff in just a moment. But in general, the procedures are, with the head frame attachment. This can be done either under a sedative manner or under local anesthesia. Patients will have MRI and CT scans done. They will have top of their head shaved, cleaned, prepped, anesthetized. Excuse me. There'll be an incision on the top of the head, typically behind the hairline, but depends on where your hairline is. And we'll make 2 small holes, somewhere in the neighborhood of a nickel in diameter, and that's about as big as we need. We will place the electrodes and test them. So there are different types of testing. First, we'll do some recordings and listen to the neurons in the brain, and I'll go through that later. And then we go ahead and we test the actual electrode itself. That's one of the advantages of being awake during the procedures. We can immediately test and make sure everything is okay. The second part is the battery implantation. So as you see in this lower screen, the cartoon version, you see the battery in the chest and the wire under the skin. In the actual patients, you can see the incisions, but remember, all the wiring is inside under the skin. There'll be no wiring sticking out. The second part is done as an outpatient. What I didn't mention in the beginning was the first part is the patients are as an overnight stay typically. So they'll have the procedure, spend the night, and go home the next day. Programming can be done at almost any time after the battery is implanted. Typically, we'll wait about a week or so, let things kind of simmer down, get back to normal. Patients may notice we call it a honeymoon phase with the electrode implantation. We want that to kind of pass, where things become more baseline, and that allows for more accurate programming. Programming is easy to do. We just put the devices, we connect them to these remote programmers, and this can be done at the office at any time. And I'll show you a live demonstration later on. Well, during the more traditional surgeries, we have this pretty much advanced headgear we use to implant the electrodes. If you see on YouTube a lot, you'll see some of this, and then you'll see patients doing all kinds of things in the operating room, depending on the indication, playing guitar and such like. Typically, a lot of the procedure is done beforehand, where we use computers to look at the brain MRIs and map out exactly where we need to go. I equate this similar to a pilot going for a plane flight. They always have to look at the charts, look at the weather, chart everything out, create a flight plan. And so that's what we're doing, creating a flight plan, a DBS plan, and it's all done before we make incision. We typically look at 3 different targets, the thalamus, the globus pallidus, and the subthalamic nucleus. For Parkinson's disease, we pretty much narrow it down to either the GPI, the globus pallidus, or the subthalamic nucleus, or the STN. There are many studies that have looked at one versus the other with regards to outcome in Parkinson's disease. It's nearly a draw with regards to how effective they are. Some things that we do notice is that with the STN target, patients end up needing less medications later on. So for some patients, the GPI may be better, especially if there's a lot of dystonia, or patients really require medications for some other issues, and they may need to maintain medications and are having medications motor side effects. So GPI is very good for that. I would say it's probably 90% of the time we do subthalamic nucleus, about 10% of the time we do GPI. Now this is a schematic of a brain on the right-hand side with some coloration. The areas that are colored are different regions within the brain. Think of this as like different countries. So if you looked at a colored map of Europe, you can see all the different countries. And you can think of these areas within the brain, different regions do different things. And they speak a little different language as well. When we place electrodes, the electrodes will listen in these different regions. And you can see the lines on the left-hand side where you can see how these lines kind of change. This is all like a static sound that we hear, but the static sound's different. So sometimes it's louder, it's a higher frequency or a lower frequency, depending on where in which region we are located. So it's kind of like walking through or driving through Europe, where you start out in Spain and you hear Spanish, and then you hear French, and then you hear German. You may not understand what any of them are saying, but you understand just by the nuance that that's Spanish, that's French, and that's German. And that's kind of like what we do. We don't understand what they're saying, but we know by the nuance of where we are. While we're in surgery, typically we'll have associates there as well, neurologists or physiologists that will be present, assisting me with evaluating the patient. The patient, as we do recordings or we do stimulation, we'll be testing the patient, asking the patient questions. Move your hand, say some words, we'll do some adjustments, and then so on. And we'll help fine tune what we're doing. What we have now also is another option to offer patients. So on the left-hand side is the more traditional awake DBS in the standard operating room. And this is still a very popular and probably the most common procedure done still today. But on the right is what we call a sleep DBS. And this is a procedure that basically we're implanting the same exact device using a completely different method. And this allows the patient to be completely asleep. It's generally anesthesia. And we implant the same device. It takes about the same length. And overall, for the patient, everything is the same except in one they're asleep and one they're awake. And we're looking at patients, how are they doing afterwards? Is one procedure more effective than the other? Are there more complications with one procedure versus the other? And so on. And in general, it's pretty much a draw. There doesn't seem to be any big major advantage of one over the other. So if that's the case, then if the patient wants to be more comfortable and they don't want to be awake, they can be asleep for the procedure. And that seems to be a growing trend over the last several years. And we offer both of these here. We can do customization for whatever the patient wishes. Again, some of the differences between the awake and the asleep procedure. The time of surgery, the time it takes to do the procedure is roughly about the same. There are no brain recordings, obviously, in the patients who are asleep in the MRI. There's no need to at this point, and difficult to do in the MRI environment. Another thing is the patients don't need to hold the medications the morning of surgery in the asleep, where we typically ask them to do so for the awake, especially since we're looking for positive effects on their Parkinson's symptoms. Here you can see the before and after with regards to outcome from DBS. So you can see the patient on the left, he has a hard time getting out of the chair. On the right, he got up all by himself and he can walk down the hallway pretty normally. Still has some problems, but quite capable, and this allows him to help take care of himself more during the day. So these are both without medications at this time. With regards to tremor, this can be done. This lady has essential tremor, but patients with Parkinson's disease can also have debilitating tremors. And so this lady just had surgery, and we're going to be turning her on right now. And you'll see slowly that the tremor in the left hand will improve. This lady is left-handed. And you'll see slowly, we're doing it remotely. So some of the newer technology allows for remote programming. There you go, you see, so, and that's just the first try. And we'll start to fine tune it here in just a bit. So you can't see myself, and the programming person is off to the right out of the screen, but we are there, and I'm telling her to move the bottle. You can see how good that is. So she could drink with that without any problem. Yeah. And really, it's little to no side effect. They'll feel a little tingling in the arm or in the mouth, but it typically fades. And this can last for quite a long time. It is variable. Improvements can last for years in most patients. Average is 4 to 5 years, but I've seen patients go 10 years and have very good result. Typically, we do programming 1 to 3 weeks after the DBS surgery. It's done in a stepwise fashion. Rarely we hit it right off the bat perfect. Typically with healing and all, patients will return within a few weeks saying, you know, it was good, but it faded. And some of that has to do with just the healing process of what we did. And we can try different settings as well. So nowadays with very advanced programs and computer assist programming, we can get very good effect with less power. Risks of surgery are relatively low. Overall infection rates are relatively low, about 1%. Bleeding in the brain was listed as 1%, but I think with newer techniques and the intraoperative MRI, it's gotten less. Neurologic complications are pretty rare, and most of these are stimulation induced and can be adjusted. And nowadays with directional stimulation, more advanced technology that's come out in the last 5 years, we can reduce some of these and maintain better efficacy of control of symptoms. Device hardware problems, so broken wires or a bad battery or something like that, is pretty rare nowadays. There have been upgrades in some of the devices and techniques on how we do things and where we put certain parts. And this is pretty rare, so less than 1 in 100 times we see something like that. So you can see the picture with the lady with the stimulator we just turned on. She's one of our 1,000 DBS surgeries that we've done in the last 24 years. So general outcomes, and this is just data from some of the literature I discussed earlier. So the top bar graph shows motor complications. And so what we mean by motor complications is these are problems with patients with Parkinson's disease. This has to do with tremor, has to do with the rigidity, the speed at which they move. The left bar is before DBS, so their native state, and the right bar is after DBS, after it's been programmed. You can see significant improvements both in their motor problems and also pretty significant decrease in medications. I mean, we in our own group see anywhere between 20 and 40% decrease in medication use after patients are tuned with the DBS for Parkinson's. So that was the major improvements, but we also see some other improvements with DBS in patients. So general well-being has been noted to be better after DBS. The way patients feel about themselves, you know, it's nothing like, you know, eliminating the tremor, significantly decreasing your dyskinesias, being able to get up and walk around on your own without asking someone to help you all the time makes a big difference in somebody's just mental well-being. So these are just some of those things that we've seen as well. with regards to what's going on in the brain when we stimulate. So we had this question some years ago. We actually did some research on it, and this is animal studies. And we looked at the area in the rat with regards to their substantia nigra. So if you look at the upper panels, you see inactive stem. So these are animals that were lesioned, meaning they were given Parkinson's disease. The intact is normal. And then there's active stem, so they had STN DBS. And again, lesioned is the same as the one above. They were given Parkinson's disease. And in the intact, they were normal. Okay. And so what you can glean from the far right panel is that the bottom one has more speckles than the upper one. And what that's saying is that there are more neurons. So something was going on with the DBS, causing the cells to survive better. So this has been a bit controversial. There are several other studies out there that have also shown this. There's no study that shows that DBS is worse and makes things worse. All the studies are showing either same or better, and most are showing better. And in clinical studies, this makes sense, and this helps answer some of the questions that I'll be showing you in just a moment. So here, if we look at neurostimulation for Parkinson's disease, who have early signs, and we intervene on an early stage, so around 4 years, give or take. And you see the two bars. So the top bar is medical therapy only, and the bottom line is patients with DBS. I think a smaller number is better. And you can see this is a 2-year graph. So after initiation of therapy at 0, they're all about 30.2. After initiation of DBS, patients go to 18.9. And they maintain a statistically significant difference from the medical therapy group spanning at least 2 years. So, and the slope at which that is changing is, if anything, similar to medical therapy. It may be different if you carry it out even further. And I'll kind of go into this here. There have been some studies recently, as 2014, that are suggesting that deep brain stimulation may actually improve survivorship. Now, this is a little bit of a big deal to say that, yeah, STN DBS may keep you out of the nursing home more likely than if you didn't have DBS. And it was a difference between 5% for the DBS side and 30% for the medical management. And you can see from this graph, let me explain this graph here in just a minute. So this is a graph, years on the bottom, and survivorship is on the top, or on the left-hand side. The top line is patients with DBS, and the bottom line is the patients with medical management. So just standard care, yeah? And if there was no difference between DBS therapy and medical management, they should overlay each other and they should all look identical. But you see, especially as time goes by, they separate quite a bit. And what this is showing me, that so like a good point to look at is year 8. And if you look up at the medical management group, which is the lower line, about 50% of the patients are surviving. If you go up to the DBS side, somewhere in the neighborhood of 80% of the patients are surviving. That's a pretty good amount of, and what they're thinking, one of the reasons is since DBS improves some of these motor problems that patients have, so they can get up and move around better, they are more mobile, they are more active, just that allows them to survive better. So the increase in activity, as opposed to being so debilitated they can't get out of a chair, they can't get out of bed, you know, and they become very debilitated. Once they become nursing home bound, then it becomes a big problem. And staying out of the nursing home was one of the biggest things that they saw in this study. So some take-home messages. DBS improves slowness, tremors, many of the cardinal symptoms of Parkinson's disease in a vast majority of patients. This is after a quite extensive vetting process. Most patients are able to reduce significant medications and lessen some of the medication side effects as well. DBS has also been shown to improve other things than just the general characteristics of Parkinson's disease, you know, like the tremor and the slowness, but things like improved sleep and just feeling better. Patients have noticed that with DBS. DBS has been shown to be superior in long-term management of symptoms as opposed to just use of medications. So there's some other cutting-edge therapies out there, stem cell treatments, still experimental. It's still going to be some time. I think some of the genetic engineering may be a little more fruitful. It's still some years away. There's some discussion now with immunotherapy, with that protein, the garbage that I talked about earlier in the cell, trying to remove the garbage inside the cell. So there's some studies like in Alzheimer that they're doing that's akin to what's going on in Parkinson's disease. So, but they haven't gone there yet. There's some basic science stuff that looks promising, but it's still some years away. Future treatments with regards to interventions. So opticogenetics, so we can genetically modify cells and have them react to light rather than to a neurotransmitter. So change the way the cell behaves and just have it on and off with regards to a light beam. It's a bit primitive right now, but it's a fascinating work. And you can do this in animals readily nowadays. It is not for prime time yet. It is very sophisticated. Requires also what we call viral vectors to give a special protein into the cell to allow it to react to the light. I think one thing that's happened in the last 5 years is more competition in the market for these devices. It's nothing like competition to spur on new innovation. So you always have to one up the next guy. And this definitely benefits patients by better devices, easier to control devices, you know, more sophisticated programming, new programming paradigms, things like that are all coming out almost, you know, on a yearly basis now. Smart DBS, there are a few places working on this. It's still very primitive, but the concepts are to listen to some of those signals. So when we listen to the different, i.e. Spanish, French, German, as it were, we're listening to those different languages within the brain and thinking, can we hone in on one of those sounds and make adjustments with regards to how that sound changes? And so basically creating a closed loop system that can self-adjust. And there's some rudimentary experiments that have shown that this can work. It's just so sophisticated, they haven't miniaturized everything to work properly yet. But it's an idea, a pretty good idea right now. And I'll be ready for any questions.
Great, thank you, Dr. Mandybur. That was very interesting. I think we'll wrap up your presentation. To those of you at home, please feel free to submit your questions through this program or via email. We will provide a response in the next few days. Again, this webinar has been recorded and will post on our website shortly. We hope you enjoyed tonight's presentation. This is the last program in the Brain Talk series. We will take a break for the summer and resume our programming in the fall with some fresh new topics. Please feel free to check out our website, mayfieldfoundation.org, for updates. And I'd like to thank you again, Dr. Mandybur, for joining us, and for everyone this evening, and have a nice night. Thank you.
Thank you.